Good afternoon, everyone. Thank you so much for joining our best practice call. Today we have two amazing presenters with us, so we are going to go ahead and get started. This is the Empowering Dialysis Professionals Advancing CKD Care and Vaccination Practices, and we're going to go ahead and have Tiffany Arlington kick it off and introduce our first speaker.
Good afternoon, everybody. Thank you for joining the call. I want to introduce our first speaker. Her name is Tawana Simpson. She is the facility administrator of Fresenius Dialysis Care located in Seymour, Indiana. And just to give you a little backlog, one of the inspirations that I found at her facility was that although we are experiencing heavy vaccination fatigue across the board, she has actually implemented a culture within her facility where just about 100% of her patients have received vaccinations. So I wanted to bring her on to just to discuss about some of the nuances that she has at her facility that maybe you can implement at yours if you're struggling with vaccination fatigue and hesitancy. So let's have Tawana Simpson come on. Are you there, Tawana? There you go.
Yep. Good afternoon, everyone. Hope you're having a great day. It's raining here where I'm at, but this too shall pass. Just going to talk a little bit about our vaccination success rate. Honestly, I cannot take great credit for it. My staff are absolutely wonderful. So we'll just talk a little bit what we kind of do as a group to try to get to where we're at. So if you want to move to the next slide. We have, like it says here, a staff leader is assigned for all the vaccines given at the facility here. That is my charge nurse. And she and I meet pretty frequently to see where we're at, who needs what, as far as whether it's flu season or hepatitis B or whatever it might be. Each vaccine is explained to the patients, and so I know a lot of places they just try to basically give them all at the same time just to get it over and done, but we find with our patient population sometimes that seems to be a little overwhelming, so we kind of try to spread them out a little bit, so that way we actually have a little time to talk with them about each one and their importance. The patients receive the education regarding the vaccine, both the printed material and, we give them verbal education on the importance of each one of the vaccines that we offer, which here is flu, pneumonia, and Hep B is what we offer. So, and you can proceed to the next slide if you'd like. So we generally try to approach the patients more in a, this is something your provider feels that you need to have, as opposed to just saying, well, we're offering the flu vaccine if you want to get it. Because sometimes, I mean, I'm going to be honest, even myself as a person, I probably don't have all the vaccines that are offered for someone, because I probably, have a hard time getting all that done. So we try to approach it in a manner to where we don't want to say it's not an option, but they feel like they can feel the importance of having it done. And the education of why it's especially important to them, just because they are ESRD and they're going to be more likely to have a lower immune response, and they're in a relatively small room with a lot of other people who may be sick or have issues, or they're more likely to be hospitalized to where they may come in contact with some of that. And we go ahead and have all of our consents prepared for the patient signature, along with the education, but the VIS, we give them that as well so they can read through that and see if they have any other questions. But we have the consents prepared and ready, so that way, once the education is complete, we can go ahead and have them sign those and be prepared. That's kind of especially important with the flu vaccines because we try to start those. Fresenius usually will let us know when the vaccines are likely to ship, and that way we have everything checked off, ready to go, and all we have to do is give the vaccines. And you can go to the next one. If a patient does refuse a vaccine, the IDT is aware, and we discuss, excuse me, discuss it in our weekly IDT meetings, so each of us can appropriately follow up as to what we need to do. The patients are informed that they can have their vaccines at their local physician's office, pharmacy, etc. And if they tell us they've had that done, we do let them know that we will get those records from that provider. And another piece of it that is important, so we can record that in their chart and reporting updates, because I feel like sometimes, like at my previous employers, sometimes the documentation is the hard part to get it all in correctly for the uploads. So you can go to the next one. We do run our vaccination reports at minimum monthly to ensure that all the patients are captured accurately. Therefore, any documentation errors hopefully are caught during that month, so we can have a strong month as far as what we have accomplished. Their statuses are always reviewed with the plans. When we get new patients, we review those with each patient at admission, so they can hopefully consent to those upon admission. Sorry. You can move to the next one. I think just at the end, it really is just more about having a good working relationship with your IDT teams, and so that way each person can follow through if there are any questions that the patients might have or anything such as that. And that's really all I have. Is there any questions?
It looks like we have a question from George. George. George Glisson, do you have a question? Your hand is up. Okay, maybe he's having some technical difficulties. Only question I wanted to ask you, and I know we discussed this further, in regards to your campaigns, how do they go off? Do you do them earlier? Do you do them later on, closer to the influenza season? Because I do know that obviously early awareness can definitely help with those pre-conversations versus, the latter.
Yeah, we usually start, usually it ends up being a few weeks before we're expected to have the vaccines in the facility. So that way patients can have time to ask questions. We can get all the education out. And we often find that several patients will usually get them at their pharmacies or something, because we have a pretty good population and they often want to get them even before we have them available, usually in clinic.
Thank you so very much. Are there any questions? Well, yes, there looks like there is one from Ashley. How do you balance providing education to patients who refuse versus making aware you are pressuring them?
I don't feel like we pressure them. We just circle back and often just say, just wanted to check back in with you to see if maybe you've gotten your vaccine, whichever one we're talking about, elsewhere, or if you're interested. And if they say no, then obviously that's their right to do so. So I don't feel like we pressure. We just kind of try to stress the importance of it.
Thank you. Melissa, you have a question?
Yeah, it's like a speculation. Have you noticed a difference in your vaccine acceptance rates since the COVID vaccine and all the talk and everything that's went on? I never had an issue getting people to agree to vaccines until in the last like 2 years. And now everybody seems to be very resistant to it.
I can't really say here we've had a lot of that, but obviously we do hear that. But luckily, and also we have our physicians also are part of the IDT team, so they also will speak to them. So that way, if they are refusing, they can also have that in their notes. But you are right. There's been probably more pushback than there has been in years past, but I think the flu vaccines especially are just so common to people that, and we don't offer the COVID vaccines here anymore. So like I said, I think the flu vaccines are just so common to people. They don't really push back too much on that.
Thank you. There is a question in the chat. Are there units who are still able to obtain COVID vaccines to administer in the dialysis unit? Tawana, I'm sure you can answer this for Fresenius units. I believe, and just please do not quote me, majority of the smaller units, the independents, and speaking on a DaVita standpoint, I don't believe they're offering the COVID shot, but you are definitely able to receive it outside the clinic, and they still are applying it to their records. And just to give you a little backlog in regards to the guidelines for CMS, it is not a quality improvement requirement. However, we're still monitoring it. So if you still are receiving vaccines from a patient standpoint, please still administer that information. Tawana, you can answer from a Fresenius standpoint as well.
I know here at our clinic we are offering them. Our physicians are just encouraging people to get them at like the local CVS or Walgreens kind of clinics.
Wonderful. And it looks like Donna says that DCI is still offering the vaccines for COVID, which is wonderful. Yes, patients are reluctant post-COVID. And I don't even just say patients, I say the general population across the board, the entire United States, across the world. Vaccines have been going in the downward stream or trending downward. But again, we are still encouraged to provide awareness. And of course, my objective is obviously moving forward with the Healthy Living Initiative, which is basically approaching a patient holistically versus just vaccines. We want to definitely encourage them to take care of their wellness, mental, social, financial, occupational, spiritual, whatever it may be, so that we can tap into those barriers that might hit when it comes to vaccines. Because again, it's a trigger. Vaccines can be a trigger based on a bigger issue. So are there any other questions? There is a comment. I have more percentage of staff than patients refusing vaccines. Yes, it's hard. It is very hard when it comes to the staff. I know before when COVID hit, it was one of those, it's a mandatory, and now we kind of gave it a little bit leniency. Again, it's the general conversation across the board, not just with ESRD patients, but across the board. So, but again, you continue to keep encouraging and working with your staff. And I'm not here to give a soapbox speech, but continue to work with your team. Tawana, do you have anything else you would like to say?
No, I don't think so, other than the best, like I said, I think the best we can do is just educate, and, obviously people have the right to think or to refuse what they do want, or they don't want to take. And we just try to make sure that we're encouraging and educating. And like I said, we just circle back and for those refusals, just to kind of make sure that, they haven't changed their mind. And if they do not, then, it's kind of a so be it, and we move on.
Right. Thank you. And I also encourage facilities individually, if you do have access to, or you do not have access, please get access to your state immunization board. As Tawana has mentioned, if you receive it outside the clinic externally, you have the capacity to receive registry to your state registry board and can see if the patient forgets, if they forget to bring it in, if the family forgets. If you get access, you're able to see that updated information. Thank you so much, Tawana, for your presentation. I look forward to working with everybody moving forward for the vaccination season. And I pass it back to Michelle.
Thanks, Tiffany. And I will have Yvonne give us a little bit about our next speaker.
All right. Hi. I'm really excited to introduce someone who's doing incredible work in the world of kidney care and patient education. He's been a driving force in helping people with chronic kidney disease better understand their condition and feel more confident about their treatment options. And what really makes their approach stand out is that he brings a whole team together, working side by side, nephrologist, nurse, dietitian, social worker, to support patients from every angle. So it's truly a collaborative, patient-centered model that really makes a difference in people's lives. So Dr. Remmer is here, and he's going to share with us about their great chronic kidney disease navigator program that they run here in Vermont. So I'll give it to Dr. Remmer. Dr. Remmer, can you hear us? Wait, we can't hear you.
Can you hear me now? The camera's not working, and I'm not sure what I lost. But can you hear? Somebody say something if you can hear.
Yep, we can hear you now. Thank you.
Okay, great. So thanks again for inviting me to talk about the Chronic Kidney Disease Navigator Program in Vermont. We're a little homegrown program, but hopefully you'll find this interesting. Next slide. So what I'd like to talk about today is to give you a quick review of the history of the program's development, an outline of how the program operates, a summary of some of the outcomes from the program. And I was worried I wouldn't have time to do this, but I think there is time now to let you see a few impressions from patients who've participated in the program. So next slide, please. I've been interested in systems for managing chronic kidney disease for longer than probably most of you have been alive. But starting in about 2010, I really started paying attention to the work that was being done to develop and then ultimately run ESCOs. And the one that I found most interesting was the work done by Doug Johnson at DCI developing the CKD REACH program. I must admit, my early interest was largely driven by trying to figure out how to reduce costs, both in the care of patients on dialysis and the transition from chronic kidney disease to end-stage kidney disease. And I talked with our ACO for a long time about trying to develop some sort of a system of care. And at the very end of 2019, I was kind of surprised that they told me they'd like to give me a lump of money to develop a program. So beginning in 2020, I was kind of in the position of the dog that had caught the car. I'd been talking about doing all of these things, and I didn't quite know how I was going to do them when I was given the opportunity to develop a program. I did a lot of reading, and some of the reading involved exploring the work of Dr. Harold Freeman. And Dr. Freeman was an oncologic surgeon in northern Manhattan working at Columbia and working with a population of patients who had breast cancer in the Harlem area. And he very quickly, as more and more options became available for the treatment of breast cancer, and those options became more and more complicated, he realized that there was a real problem trying to get people to participate meaningfully in complicated healthcare, both from the point of view that large populations are not particularly medically sophisticated and they're wary of a lot of the things that are suggested to them. And maybe even more importantly, that there are large groups of people that don't feel agency in their own care. It is very difficult for them to approach a powerful organization and to try to get what they need. So he developed the idea of having chronic disease navigator programs. His happened to be for oncology, and his navigators were trained to educate patients about their disease processes and the options that they had to deal with their disease processes. But more importantly, the navigators were assigned as advocates to the patient. The navigators represented the patient, not the system of care. And I like that idea. I like the idea more than when I talked with people here about care managers. I found that people talked about care managers more in terms of representing the interests of institutions and of large organizations. So with that, although I took a lot from the CKD REACH programs, I decided that we would have a CKD navigator program rather than CKD care managers. Next slide. So this is how things developed. The program started in 2020, and as I said, I really started with a blank slate. So the first 6 months, I set up systems to administer the program, wrote job descriptions, and finally was in a position to be hiring people by June of 2020. As I noted, the pilot project was funded by OneCare Vermont. I had a fairly simple contract with them. The mandate was to see if we could develop a system that would identify patients with advanced kidney disease. And when we identified them, would we be able to engage them in participating in some sort of program for chronic kidney disease management? It's pretty open-ended. We were allowed to design and do what we wanted to do. It was only those two things that we were having to report on every 6 months or so to the ACO. The staff was small, and it remains this small. The staff is one full-time nurse, a half a dietitian, and a half a social worker. They all really like what they're doing, and I'm sure they do more work than that when I talk with them. The nephrologist, which has always been me, was funded at 0.1 initially, and that has been reduced over time. So by the end of June, I'd hired everybody, and we were ready to begin. So in July through October, we basically went out and read all the literature for teaching materials, the best way to educate chronic kidney disease patients about their diseases and about their options. All of the navigators went through special training for difficult discussions, discussing difficult diseases. And by the end of October, we felt that we had everything in place to begin recruiting patients. So next page. So patient selection by contract with the ACO, I really wanted to do earlier chronic kidney disease and deal with slowing progression. But in their vision, the low-hanging fruit was trying to improve the transition from advanced chronic kidney disease to end-stage kidney disease. So our target population were patients that were being followed in the UVM nephrology practices with an eGFR of less than or equal to 20, and by somewhat subjective standards review of their chart, the feeling that they had at least 3 months until renal replacement therapy would be required, because we felt we would need that much time to educate patients, engage them, and change the trajectory of what was going on with them. From the very beginning, I insisted that there would be no insurance requirements for this program. So it was a pure grant-based program. And essentially, we looked at any patient who was likely to need treatment for end-stage renal disease within the University of Vermont system. So since there were no insurance requirements, there has been no billing, and so patients don't encounter any resistance to contacting us and dealing with us. They don't receive a bill for anything that we do. Luckily, the whole program started during the dead of the COVID epidemic. So I've almost forgotten at this point, but we were trying to deal with COVID all while we were trying to build and grow this program. But it forced us to do most of our encounters telephonically or by video conferencing. Video conferencing can be a little difficult in Vermont because broadband can be quite spotty in Vermont. But really, we're able to make it work. The patients seem to be very comfortable. I think in the several hundred family meetings that I've had during the course of this, only 2 families have insisted on coming in and meeting with us in person. All right, next slide. So this is how the program works. And if you follow from left to right, we identify patients basically with a computer search that shows us everybody who had an eGFR in the target range that was seen in a nephrology clinic during the prior month. In the beginning, that was hard because that was hundreds of patients. And so we had to review a lot of charts and try to set some priorities for who we would take into the program because we couldn't take everybody who would be eligible. It's interesting, after 4 years of doing this, now that is really not a huge problem at all, that we can take in almost everybody new that's seen in clinic. So when we identified a patient, initially we set up a system where the nephrology providers were going to sell the program to the patients. encourage them to participate and make a referral to us. And it was clear within the first couple of weeks that just wasn't going to work. So we stopped that right away. And we basically went to an opt-out system where we identify the patient, we notify the nephrology provider that we are going to contact the patient and try to engage them in the program unless they know or unless they feel that that's a bad idea within about 72 hours of our contacting them. So since then, we've gotten a lot of patients into the program. Once we've contacted the patient and they say they would like to proceed, we send out a fairly substantial information packet that they have a couple of weeks to review before they have their first visit with a CKD navigator. All three disciplines, the nurse, the dietitian, and the social worker, function as primary navigators. That is, they do the original patient education and they will function as the person assigned to monitor that patient longitudinally as they move towards end-stage kidney disease. In that first session, which is scheduled for about an hour, usually goes longer than that, often is a couple of sessions, they receive education about CKD itself and about what the options for managing CKD are when you reach end-stage kidney disease. 3 subsequent meetings are arranged with a patient, and that is a medical assessment by the nurse and a history, a nutrition assessment and education by the dietitian, and an assessment by a social worker and education. Frequently, 3 hours is not enough to both assess and educate the patient. So depending on what's needed, various of the disciplines revisit with the patient over time. I've been particularly struck by the nutritional and the social work needs of patients as they are approaching end-stage kidney disease. Once the education and assessment process is done, we have a meeting that we called a life goals assessment that developed out of the contract with the ACO. They like the name. It's basically a plan of care meeting where I meet with the patient's navigator, the patient, and the important people in the decision's life. And we sit down basically for an open-ended meeting and discuss whatever the patient and the patient's family wants to discuss. Even at that point in time, patients and family members frequently don't have a really clear idea of what's ahead of them. And so we talk about that a bit more. And by the end of that meeting, we try to have a plan in place. What does the patient see as the best treatment for them when they reach end-stage kidney disease? We report that, and that is basically what we're going to work towards over time, although we're flexible. We know that things will change over time. Once the plan is in place, the monitoring phase begins. The sort of standard minimum early follow-up is that the navigator contacts the patient person to person every 4 weeks and does a fairly detailed evaluation of how things are going, including assigning a symptom score. And they have laboratory work done a minimum of every 6 weeks because we found within various practice patterns, it was very, very variable how people followed the biochemical features of chronic kidney disease. The navigators then follow the patients until they reach an endpoint, and an endpoint is dialysis, death in supportive care, or a kidney transplant. An additional part of the management system is we have weekly team meetings. New patients are reviewed at the team meeting, and we try to anticipate what are the issues that the navigator is really going to need to begin to address very quickly in the new patients. We discuss problems that have arisen in patients that are in the monitoring phase, and we brainstorm solutions for those problems. And part of this meeting, the first 15 or 20 minutes of this meeting, is the manager from our home dialysis programs meets with us, and we discuss all of the patients who are moving towards home dialysis and how we can facilitate getting those patients onto home dialysis. I think that's it for that slide. Next one. So this is what we've done. In about 4 years, we contacted 432 patients with the appropriate EGFR. In that group, 334 agreed to participate in the program. So answering the ACO's question, we could get about 78% of patients with chronic kidney disease to participate in an ongoing program of management. Of those 334 patients, 241 have completed a plan of care, a life goals assessment. We are currently monitoring about 120 to 130 patients who've made their plan of care, and we're monitoring them as they try to move towards what it is that they have decided that they want to do. This is kind of the limit of what we can do. When I have looked at the CKCC multidisciplinary care teams, they look like they are composed of about 20 staff members for every 1,000 patients, so about patient staff ratio of 1 to 50. So we're maintaining a ratio significantly higher in this program where we really only have 2 FTEs. It's limited us having everybody in Vermont go through the program, or everybody interested in Vermont go through the program. So of the 241 with a plan, 130 patients with a plan reached an endpoint. And again, just to repeat this for you, an endpoint is that they reached dialysis, kidney transplant, or death in a supportive care program. Next. I find this interesting. This is the choices that people make. And this is a pretty good reflection of what a population in Vermont might choose. Because if you think about it, all of these patients have gone through a very standardized educational curriculum and had the same approach to helping them decide what they would like to do. So given that, still about 35, I know I'm sure can't read the legend on it, about 35.5% of patients still saw themselves as only being able to do in-center hemodialysis. And we have a little bias, as you might suspect, against in-center hemodialysis, but certainly all of us have done dialysis for a long time and understand that in a rural state, that's the only thing that a large number of people can do. 28% of patients say that if they could do what they wanted to do, they would want to do peritoneal dialysis. About 13.5% of patients said that they would really like to try to pursue a preemptive transplant before needing dialysis. About 10% of patients felt that they would never want to undergo renal replacement therapy, that they would want medical therapy alone and supportive care. Try as hard as we could, about 8% of patients were unable to make any sort of decision while going through the program. So we just sort of monitored them, trying to remind them something's going to happen to you. It would be great if we had a plan in place. And so we had that 8% who at least initially didn't have a plan in place. And poor little home hemodialysis, we keep trying to figure out what we can do about this, but only about 4.5% of patients felt that they would want to do home hemodialysis. Next slide. So in this group of a couple of hundred patients who had a plan in place, 103 of them reached the endpoint of dialysis, kidney transplantation, or death in supportive care. And so a few selective features of outcomes in these patients are that 76 of those 103 patients actually reached the therapy that they said they wanted to do way back at the time where we had the planning meeting, and we asked them, what do you see yourself doing when you reach end-stage kidney disease? 74% of patients chose the therapy that they ultimately ended up doing. In those that planned dialysis, and that was 50 of the group, but those who had a firm, longstanding plan for dialysis in place, 49 of 50, or 98%, had a permanent access in place when they reached dialysis. Of those who started unplanned dialysis, so people saying they didn't want to do anything, people who were hoping for a kidney transplant for dialysis, non-dialytic pathways ended up not being the pathway that a patient followed. There were 16 of those patients who had not been planning to start dialysis, and in only 4 of them, or 25%, were we able to get a permanent access in place by the time they started dialysis. But if you look at the overall group, 66 of the group started on dialysis, and 53 of those had a permanent access in place. So of the whole group going through the program who ended up on a dialytic endpoint, 80% of them had a permanent access in place. Next page. Ooh, that didn't survive. So I'll try to point out what's going on. So almost everybody asked the question is, so when people made a decision, what is the distribution of what people actually did based on the decision they made? And so there was supposed to be a column of LGA decision that's become kind of disrupted, and a column that shows actual endpoint. So LGA decision is what people said they wanted to do. Actual endpoint is what people ended up doing. So 44 participants said that they wanted to be on in-center hemodialysis, where I bet this isn't surprising to any of you. 54 of them ended up actually doing in-center hemodialysis. And the reciprocal of that is that 30 patients had selected peritoneal dialysis as the most desirable therapy for them, whereas in the group that actually had to start something in the group, when they started something, only 19 patients started on peritoneal dialysis. Really surprising to me, there were 11 patients who, prior to dialysis, elected to have no renal replacement therapy. And email me if you have any baseline data on this, because I have not been able to find any good baseline data about decision-making about supportive care before dialysis. So I don't know if this 10% of patients or so is typical or atypical. But the thing that I find very interesting, and one of the things we're trying to explore what is going on, that when people actually had to make the final decision about starting some form of renal replacement therapy, twice the number of people decided that they really didn't want to start any form of renal replacement therapy. 7 patients said they wanted a preemptive transplant, and I was pretty surprised at our success that 6 patients had a preemptive transplant. There were the 6 undecided patients, and when you look at what happened to them, 3 of the 6 ended up in supportive care and hospice, and 3 of the 6 ended up in in-center hemodialysis, all of them with a central venous catheter. 5 patients said that they would like to do home hemodialysis, and 3 patients ended up doing home hemodialysis. Next slide. And this is just a graphical representation for those of you who think visually rather than in a table. So the left-hand panel are the LGA decisions, what people said they wanted to do, and the right-hand panel is what people ended up actually doing. So again, about 43% of people said they wanted to do in-center hemodialysis, while about 52% of people started on in-center hemodialysis. About 30% of people said they wanted peritoneal dialysis, while around 18.5% of patients started on peritoneal dialysis. 10%, 11% of patients said that they didn't want any form of renal replacement therapy and they wanted medical therapy only. And again, here you see that great big jump where 10% said that's what they desired, while at the point where they really need to decide, are you going to begin some form of renal replacement therapy, about 20.5% of people said, no, I don't want to do that. Again, about 6.5% of patients elected to have a preemptive transplant, whereas about 6% of patients achieved an elective transplant. We have about 6% of patients who were unable to make up their mind, and obviously they disappeared where end-stage renal disease happened. And about 4.8% of patients wanted to do home hemodialysis, and about 2.5% of patients actually ended up doing home hemodialysis. Next slide. So I can't really absolutely show you that we're improving outcomes, but I can tell you, I've already told you, that about a third of our new starts on dialysis go through the program, and about 2/3 of the patients don't go through the program. So I can tell you about what happens to patients if they've been through the Navigator program versus those patients who started our institutions who've not been through the Navigator program. And so if you look at modality, this is just for the year 2024. This is an all patient, so the number is going to be a little different, some of the numbers that I've told you. So in the 2024 new starts, 32% of patients who went through the Navigator program and started dialysis started on a home modality. Whereas in the group of patients who started dialysis and didn't go through the Navigator program, 2% started on a home modality. If you look at whether or not patients had a permanent access, we didn't do quite as well here in the Navigator program as we did overall. But if you look at those patients who went through the Navigator program, a little over 50% of patients used a permanent access. Others had a fistula in place that wasn't ready to use, but 52% started using a permanent access. Whereas in the no Navigator program, 22% of patients started with a permanent access in place. And the final thing to show you is whether or not patients started as inpatients or outpatients. If a patient went through the Navigator program, a little over 3/4 of them started in the outpatient setting. Whereas if you didn't go through the Navigator program and you started on dialysis, about 40% started as an inpatient, about 57% started in the inpatient setting. So that's about all I wanted to tell you. If we can go on to the next slide, about how the program works. But as I said, I really started out in this thinking about the financial benefits of it to the system. And over the years, as I've talked to more and more patients, I think I've been converted to the idea that the peace of mind, the reduction in anxiety that patients and their families receive when they go through the program may be the most valuable part of the program. And that is on top of the fact that although I'm working on being able to prove that we're saving the system money, and the numbers suggest we really should be, I believe really are saving money. I think the patient's voice, the patient's experience really tells you something about the value of the program. So, Michelle, you want to see if this can be played?
Yes.
For choosing peritoneal dialysis, it was nice to be able to get kind of a look into each type of dialysis that was available. I had only known of just the basic dialysis, hemodialysis. I didn't even realize that there were two other tracks you could go to. And it was nice to be able to go to the dialysis unit and get a glimpse at what each would have and offer, as well as it getting explained, how it would affect what you could eat and drink and all of that. Kind of put everything together into, 3 different boxes to be able to evaluate which would fit my lifestyle the best. It definitely helped in nutrition. I knew somewhat about nutrition, but nutrition is definitely different as a CKD patient. Certain things are good for you, but you don't know what are good or better or not as good for kidney function. So that was a huge plus in learning that aspect of the nutritional part of dialysis and how it affects and kind of opens your eyes to a different avenue, I guess, of nutrition as opposed to just a basic. I don't know how to explain it great, but it definitely was learning a different part of nutrition was a big help than just as a healthy individual. It's different, and it guided me to understand how, what was good and what was better to do in my health wise. It definitely gave me a lot of information. It also guided me to get a peer through, was it the NKA? It set a very good foundation for what was ahead of me. It was good to have it kind of in pieces. So when I started dialysis, I wasn't also getting a nutritional aspect of it. I kind of already had a base for it. So that made everything a little bit easier. It definitely set me up for a little easier transition into it all. It was gave me a good foundation and made things a little easier to slide into, knowing what to expect and knowing how to go about being successful. And I don't know, I don't think I'd be where I am without the program. It definitely, for me, was a huge help in many aspects.
It was a lifeline for us. It gave us peace of mind when we didn't know what was going on. My husband was a physician, a family physician, so it was a little different because he knew he had his own patients on dialysis, but he also had a severe heart problem. It started out not quite as severe, and then the kidneys kicked in, and then later Parkinson's kicked in. So we had quite a complicated issue. But when we started the program, we were wanting to look at home dialysis, hoping Bill could use it. So we went up and got some training in it and everything. And then within a few weeks, his heart got worse. and we found out we couldn't use any dialysis at all, which was, we were sorry about that, but the heart was just getting worse. So um, the Navigator program, Sydney, we look forward every month to our Lifeline and to talk to you, because you not only talked about his kidneys, you asked about his heart and his blood pressure, how he was feeling emotionally. You, and you treat, being a physician, he really loved working with you, like he did with all the professionals he did in his life, his medical professionals. So unfortunately, as the heart got worse, we ended up, the end of our journey was supportive care and hospice, which also I would speak to as a wonderful program for people. So even though we couldn't use dialysis, we used all your dietary advice. Um, he also had diverticulitis a lot, and boy, you helped us a lot with that, because that caused him a lot of pain. Um, so, and the total peace of mind knowing you were out there, and that even though your time wasn't coming up, maybe in a week later, I could email you and ask a question or whatever. And incredible program, because to know you can't always call your doctor. So you were the connection for us between what we were trying to do and what the doctor was asking, and it was incredibly helpful.
I had polycystic kidneys, and my father had it before me. So I've known about it since 1984 that I had the kidney disease. So I've had plenty of time to deal with it. But by the time I was getting closer to the end, getting involved with the Navigator program, I think clarified a lot of points. Really dealing with nutrition primarily to make sure that you're on the right path to try to prolong your kidney function. And then, your psychological aspect and dealing with it, as was always a key element in every meeting, every monthly meeting. For me, it was important for me to remain active. So part of the Navigator program was choosing what your next step was going to be. And so evaluating the different types of dialysis, my father was on peritoneal. I thought I was going to go that same route. My kidneys were too large to accommodate my abdomen. So hemodialysis was my choice. And we went home hemodialysis, which allowed us a lot of flexibility, and it was done 4 times a week. And I had the benefit of my wife as my caregiver. She was very much involved with the program with me. And so without her, that option wouldn't have been possible. So the monthly meetings were very valuable. If evaluating the options, ultimately what I really wanted was a transplant. And if it wasn't for discussions with the Navigator program, I wouldn't have gotten that choice. Because I have another disease, which is chronic lymphocytic leukemia, which is a cancer that's not curable. And some hospitals won't do a transplant because you have cancer. However, through the program, Boston Massachusetts General Hospital was investigated as an option, and they really looked at people individually and not just a blanket statement that if you have cancer, you're out. So without that comment from the Navigator program, I don't think I would be today with a new kidney that I'd gotten in December 3rd this past December 3rd. So I'm 3 months into a new kidney and it's working very well. And for me, being outdoors, skiing, hiking was always a very big part of our lives, my wife and I. And so being able to do that was key. And so the Navigator program, I've gone through 3 years of hemodialysis at home, and then eventually getting a kidney transplant. So I think there was a lot of benefit involved, and more than just the psychological and the nutritional aspect, but ultimately getting to the point of actually having a transplant.
So I think that's it for my presentation. I'm happy to talk with you about any questions that you have.
Does anyone have any questions? We can enter them in the chat, or you can unmute yourself. I see lots of hands clapping. I think the patient video at the end really brought it all together. It's nice seeing how all that hard work is impacting.
Yvonne, this is Vicki. I just for Dr. Elmore, we've heard about your program, always very excited and the work you're doing. Have you been able, I know you were getting funding from a grant, and before you said you were looking for other sources, and this isn't often reimbursed. Have you been able to find continued support for your program, or is the hospital continuing to support you with it?
So that's a difficult question. Where we're going to be as of October 1st this year is not entirely clear. It's been funded by magic. People have realized its value, and I have been steadfast in not wanting it to be a fee-for-service program, because I think it will limit its utility to the group of people that need it the most. Right. So I've tried to stand in front of that. It's an interesting process, very difficult. I'm going to choose my words carefully here. But people seem to understand the value of making widgets and generating a fee for each widget that you manufacture. It is much more difficult for them to understand that you equally affect the balance of your finances if you can reduce the cost of producing a widget. And that's been hard for us locally, and we're moving. We're trying to move to show that we really are reducing the cost of patient care, and that reduction in cost should be used to fund the program. And it's hard in a little program. We are getting close. We're able to track the overall cost of care for a patient with end-stage kidney disease in the first 6 months before going on dialysis. And the difficulty in Vermont is care is really economical in Vermont in the first place. The annual average cost of care of a dialysis patient in Vermont looks like it's about $83,000. And don't quote me on any of these things because we're still struggling trying to get them. It looks as though in the annualized first 6 months of going on dialysis, that goes up by about 18%. So the annualized cost of the first 6 months is about $100,000. And not surprisingly, except for when you actually follow up on the numbers, the annualized cost of the last 6 months of dialysis is about 3 times the average. So the annualized cost of the last 6 months of dialysis is about $240,000. So we can say all those things about the population in general. I'm hoping we can say that those costs are different in the population that's gone through the Navigator program, but I can't say that right now. And that's the hope for keeping the Navigator program going, showing that it's reducing costs.
So if anyone, any of our listeners would want to get this going, probably get some kind of initial funding and then see if you can justify the cost by the savings is kind of the route that you've taken.
Yes, that's exactly the route that I took. And I might have gone with the CKCC program, although even that, I think they only accept fee-for-service patients. So I don't know. But we were unable to do that because we're participating in the ACO. So we already were in an alternative payment system.
Yeah, I mean, it's wonderful, and I would love more places, but it really requires thinking outside the box. But trying to figure out how we can make kind of a groundswell of these kind of programs to say, stop paying for the widget, as you put it, and pay for the prevention or the better care. So,
Yeah.
thank
And
you.
there isn't a question in my mind that it's better care. So
Yeah, no, I agree. Just even listening to the testimonials just really brings it home.
All right, I don't see any questions in the chat. It looks like Michelle has the survey in there. If you could fill out the survey about the call today as well.
Yeah. Great call, everybody. Great speakers. So please give us your feedback.
all right then. Bye-bye.
Thank you.
Thank you so much.
Thank you for joining the call. If you could please complete the survey in the chat, it will also be emailed to you. Thank you.